in one hand, we have biomedical engineers complaining about lack of jobs, lack of skills and all that. And on the other hand, we have lots of real world problems that are actually looking for biomedical engineering skills and solutions from biomedical engineers. So this is the first of the series of the webinars, and today we want to talk about a very important problem on heart attacks or myocardial infarction. We want to focus it on one specific aspect. Okay, there is something called pre-hospital ECG, and it's very important, and it's direly required, but it's not widely or prevalently available. And this is one place where biomedical engineers can pitch in, and all this series of webinars will focus on LMICs, low and low middle income countries. Yeah, we have all this innovations in science, technology, developments in healthcare, but still many solutions that work very well in the Western world do not work in a country like India, in an LMIC country like India, because there are so many differences, mostly concerning economics. This talk is given by Dr. Jayvel Armugam. Okay, myself, I am a PhD doctor. I am not a medical doctor. Okay, this is intended towards creating better awareness, and specifically awareness to BME students and engineers. Okay. Let's get a quick survey on where all of us stand. So let's go one question at a time. So what are the symptoms of heart attack? Could either use a mic or you could also use the chat.
Sir, pain in the chest.
Pain in the chest. Okay, fine. Excellent. Then, so what kind of a pain do they have? And can you add anything more to it? So this is just a warm-up question, but later I will show that even something as simple as this is actually very important. Pain in the chest. Okay. Anything else?
The shortness of breath.
Okay. Shortness of breath. Okay. Now, okay. Even before we talk about this, so what is a heart attack? Okay. Okay. Fine. We'll get into that. Shortness of breath, and then okay, chest in the pain, shortness of breath. Let's look at the next question here in the slide. Okay. That would be, how does someone with a heart attack, get to the hospital in a LMIC, that is in a low and middle income country? And that's also geographically very diverse, like India. How do they get to a hospital? Any guesses?
Sir,
Any
blocking
guesses?
of blood flow?
Blocking of?
Blood flow in the heart cause the heart attack?
Yeah, heart attack. Yeah, we'll come to that in a moment. We'll have some visuals and actually see what heart attack is. Heart attack right now is, there are blood vessels supplying oxygen to the heart muscle. Some of those blood vessels get blocked. Okay, so if a blood vessel supplying, oxygen to the hand, it gets blocked, hand wouldn't function. Same thing happens to the heart. Heart couldn't function, right? And if the heart couldn't function, then we are in a very fatal condition. That's a heart attack. The question is, say someone seems to have presumably has heart attack, symptoms of heart attack. Okay, how do you think how do you think they reach hospital in India? What kind of transport do they use? Any guesses?
Sir, I didn't
Ambulance?
question.
How, say someone thinks they have heart attack. Okay, someone in India. How do they reach a hospital? They have to visit a hospital, right? Presumably, they are not going to stay there.
Ambulance?
Okay, ambulance. What else? Any other guesses? Any absurd guesses?
Green corridor?
Okay, green corridor. This is okay. Ambulances have this special privileges for movement. Okay, fine. Again, it's part of being taking an ambulance. Any other modes? You might be surprised if I actually show what reality is. Okay, so most of you would have thought ambulances. Ambulance is certainly one of the modes, but not the only mode. And you'll be surprised by the actual transport modes used by heart attack patients in India. Okay, and then
Sir,
let's get to, yes.
sir, their own vehicle they go.
or a, someone who is there nearby next to the person takes him to the hospital. Fine, fair guess. Okay. Let's get to the next question. Okay, this is all to set a stage for where things are. What there is something called door to balloon time. Does anyone know what a door to balloon time is? Or you could, there is also something called a cath lab. Then there is something called a PCA. Any of you know about any one of these three? Of course, we can quickly Google and see what things are. But one of the things that you will get by the end of this presentation is at least basic awareness on some of this medical jargon used. Okay, that is one of the takeaways. But there are much more important takeaways from this presentation. Okay, with that, let's actually get started with some actual data. And heart attack, of course, uh, blood vessels supply oxygen to all parts of the heart, and then there are some blood vessels supplying oxygen to the heart itself, heart muscle itself. Usually there is a damage in the artery wall. Okay, there is something called plaque rupture, where the surface of the wall kind of breaks away. And when that happens, just like every other blood vessel, the blood vessel inside the heart will also clot. That is, the blood will kind of solidify, will become a polymeric mesh, and that will block the blood vessel completely so that no blood can, pass downstream. The moment that happens, the area corresponding to that blood vessel wouldn't get oxygen, and the heart cannot continue pumping properly. Okay, this is a heart attack, and typical symptoms are that someone has chest discomfort. First thing is, of course, you're going to feel some pain in the chest. Okay, discomfort in the upper body. There can be discomfort in the jaws, upper arms, neck, shoulder, and things like that. And there is shortness of breath. Part of the heart is not getting its oxygen. That automatically, you are looking for more and more oxygen. Someone feels like they are running short of breath. Okay, and there is usually a lot of sweating without doing any exercise or something like that whenever there is a heart attack. And then sometimes there is this feeling of vomiting or nausea, and then some lightheadedness. The most important symptom is that of chest discomfort, and the figures kind of show where this pain is typically felt. Okay, higher the intensity of red, the more pain is, more likely the pain is felt in that region. Okay, and the reason to actually talk about symptoms of heart attack is most people don't seem to recognize a heart attack when they are actually going through a symptom of heart attack. Okay, we unfortunately we seem to be in a situation where a lot of people don't recognize symptoms of heart attack, and subsequently they don't take timely treatment, or they don't take treatment, and the consequences, or in this case, is very, very fatal. And the title said something called STEMI. Okay, heart attack in a medical term, they call it as myocardial infarction. Okay, so MI stands for myocardial infarction, and that STE actually stands for ST Elevated Myocardial Infarction. So whenever a blood vessel in the heart gets blocked, okay, that often can be seen in the ECG. What you have seen is ECG corresponding to someone having a STEMI. Okay, that is, if you look at lead 2 and 3, okay, I suppose all of you could locate where the QRS wave is, at least certainly the R peaks. The segment following the R peaks, that is, after R follows S and T, right? Notice ST we expect to have 0 voltage, but we are seeing elevated voltage in LEDs 2, LEDs 3, and also in LED AVF, right? What is supposed to be 0 in the ST segment, it's elevated at least in 3 of the ECG LEDs show, standard 12 LED ECG is shown here, LED 2, 3, and AVF. And this is known as STEMI, or ST segment elevated myocardial infarction. And if you were to categorize myocardial infarction into, okay, somewhat less severe, more severe, STEMI kind of stands in the very, very severe case of myocardial infarction. That is what we are, particularly concerned about STEMI. And by now you could see that STEMI can be seen in a ECG. Okay, and a quick, summary of numbers specific to India. This problem is actually very, very worse in India compared to developed countries. Okay, as I said, STEMI is a very, very severe case of heart attack, right? The percentage of that severe case is actually 60%. Any acute, any sudden problem occurring with the heart, they go by the name ACS, acute coronary syndromes. There can be severe cases is STEMI, and that accounts for 60%, which is higher than what is seen in a developed country. Okay, so 60% of the cases are very serious or very severe. And also, if you look at the age, so Indian population are getting heart attacks earlier than what the developed, what people in the developed countries get. Roughly, median age close to 56.3 years. About 5 to 10 years lower is when someone gets a heart attack in India. Okay, and someone has symptoms of heart attack from that time of onset of symptom to the time they actually get to a hospital or get first medical contact, right? That time is 300 minutes. Okay, that is 6 hours. And 6 hours, to actually put that in perspective, just wait for a few minutes. By 6 hours, most of the heart is almost gone, or most of the heart muscle is dead. So that salvaging that person, prognosis is very, very, very bad. Okay, and also most of the people who have heart attack, the poor are more likely to have heart attack, and when they have heart attack, they cannot really pay for the treatment and things like that. So economic status is in general lower. And 30-day mortality, someone has heart attack, what happens after 30 days? Are they alive or dead? That mortality is actually very high in India compared to developed countries. So the problem from all perspectives is kind of very, very bad. Okay, and about 3 million estimated number of 3 million heart attack cases occur, acute coronary syndromes occur in India. Okay, this is estimated, exact numbers are not there, but very good estimations. 3 million, which is like a lot. So this is again getting back to some of the initial questions we were asking. Someone has symptoms of heart attack, how do they get to the hospital? Interestingly, in the developed world, most of them might be getting to the hospital by ambulance. In India, interestingly, we use lots and lots of transport modes. Okay, now this figure shows in the left, okay, the time it takes to reach the appropriate study center, usually a hospital. Okay, corresponding to the mode which they take. Notice they are using anything from ambulances, 108 ambulances, to private ambulances, to own vehicle, to hired transport, to public transport. Okay, in places sometimes even people take public transport like buses and trains. Okay, and that percentage is also not very, very less. If you notice about higher transport and public transport, own vehicle are kind of like more than 50% of more than 50% of the transport modes. Also notice that if someone uses a 108 ambulance, they are likely to reach a study center within 30 minutes. They use any other mode, things are increasing. Okay, private ambulance takes about 45 minutes, own vehicle takes 55 minutes, higher transport gets 60 minutes, and then public transport takes 70 minutes. Okay, so yeah, this is somewhat of a dire situation, right? Going by public transport. Okay, but that is happening. And this particular data is from South India, but it's also kind of reflective of what goes on, in the country across various states. And okay, what happens when someone has heart attack? Okay, typically, the best treatment is to do what is known as a percutaneous coronary intervention. Okay, let's say you have a blocked artery somewhere as shown in the schematic. I suppose all of you could see the brown region where the region corresponding to that artery is blocked slightly above the yellow marks. Okay, someone tries to access that blocked region through blood vessels. There are arteries in the arm as well as arteries in the legs. Some of them are very close to the skin. You could enter those arteries and you could actually get to the aorta, base of the aorta, and then the problematic infarct related artery. Say for example, one of them shown here, right? So just by entering the blood vessel somewhere in the leg or somewhere in the hands, one could actually reach the culprit artery or this blocked artery. So this way of reaching just through the skin is known as percutaneous. Okay, and this procedure is known as an interventional procedure. Okay, and it's a coronary intervention. Okay, it's an intervention regarding the heart. And doctors who do this are known as interventional cardiologists. Okay, this is a specialization. And what they actually do is they put a guide wire through the arteries to the target location. Then they put a balloon, inflate it so that the blocked artery kind of expands. Okay, and then most of the cases they leave a stent behind so that there is support, mechanical support, once you remove that guide wire and the balloon. This is a preferred mode of treatment, and this is known to work very, very well if it's done on time. Okay, so for some reason this is taking time. One of the alternatives is, okay, one of the vessels is blocked. Can we give some kind of anticoagulant to clear that clot? That is also another mode of treatment. Okay, although PCI, this percutaneous coronary intervention, is preferred, in reality, most of them are getting the secondary thing that is known as thrombolysis. Okay, that is lysis of the thrombus or lysis of clots. Okay, clearing up of the clot on the blood vessel. Okay, notice in order to do this procedure, okay, two schematics before and after PCA is shown here. Okay, if you follow the red arrow, the tip of the red arrow actually points to a location of a blocked artery. Notice the artery is marked by a dark region. The location of the tip kind of says, okay, there is no artery there, right? Essentially, there is no blood flowing there. So it is actually appearing brighter compared to the artery on either side. That is a blocked location. And the star actually shows the tip of the guide wire. You're putting some wire to actually access that location spot, then put a balloon and then implant a stent and all that, right? So that guide wire or catheter is actually seen. The end of that is seen in the asterisks. And once you do this, in the right, you have the same thing after implanting a stent. Now that, of course, that blockage is clearly removed. Wherever you have the arrow, that location, notice now we have the blood vessel properly established. Okay, so this is what happens in a percutaneous coronary intervention. And of course, by now you see you are entering the heart only through the arteries. Okay, radial artery or femoral artery. In order to do this operation, first thing is someone needs a coronary angiogram. That is this images showing where the blood vessels are, at least a 2D projection of where the blood vessels are, so that you can guide the cathode, that guide wire, and then you can see where the blockages are, and then you can also appropriately place the stent. If you don't have this imaging modality, you cannot do this PCA. Okay, so coronary angiogram is a must in order to do this, and typically the labs that have this, okay, are known as cath labs. They have this angiogram machine. They are very costly, and in a country like India, the density of such cath labs is very, very, very less. Okay, because of course some costly equipment is involved here. Now let's come to one of the important parameters in this procedure. There is something called door to balloon time. That is, say someone enters the hospital, that is the door, hospital door. From that time onwards, the time it takes to put the balloon in the actual blocked artery, the time is known as door to balloon time. And this time DTB is a very good proxy for quality measures. How good is how efficiently is the cath lab system working? Is the doctor available, at night, or is the lab ready to do the, intervention? So there are lots of questions. This particular time, DTB highlights how well a hospital is performing. So here we have three figures A, B, and C. Okay. Notice this door to balloon time is higher if you are using other vehicles. So if you are using an ambulance, that ambulance will automatically notify the corresponding emergency department, and ambulance, if it has a ECG, it will also, kind of diagnose STEMI and keep the team, the cath lab team, STEMI team ready. Okay. So if you are using ambulance, you are actually, this door to balloon time is lesser. Now, if you look at the central figure B, okay, there is a minor difference between door to balloon time in day and night. This is, of course, whether is the interventional cardiologist available at that midnight when someone had a heart attack and reached that center. So there are some subtle differences here, whether is a team ready. So there is a slight difference. The most important is that, there in the right side, figure C, notice if door to balloon time is less than 90 minutes, at least in this specific study, okay, most of the people, about 280 people, 276 were alive at the end of 30 days. On the other hand, if door to balloon time is greater than 90 minutes, about 10% of them died within 30 days. So this particular time kind of says, it's very, very important that you do this, reduce this door to balloon time and do this operation as quickly as possible, because whether someone is alive or not is actually determined by, this time. One of the times that kind of highly correlated with life or death in this scenario. Okay. So why is time so important? Okay. If you look at the damaged tissue, notice, look at the bottom figure. Okay, this is the x-axis shows time from symptom onset to reperfusion therapy. PCA is a reperfusion therapy, for example. Okay, and the y-axis shows the extent of myocardial salvage. That is, okay, part of the heart muscle did not get oxygen. Now it will stay alive only for so much time, only for an hour or two. There is something called a golden hour. After 2 hours or something like that, whatever you do, it's very hard to get back that damaged tissue. Okay, and there is a very, very steep drop. Notice there is not like a linear drop. Until 1 hour, it's almost stays at 100%. So you could pretty much get back 100% of the heart muscle activity. But the moment it goes above 2 hours, there is a very, very steep drop. By 3 hours and all that, you could roughly get about 50% of the damaged heart back. By 4 hours, you get 20%, and the more you delay, you are pretty much not getting any part of the heart back. Okay, so this timing is very, very significant. If you do PCA or thrombolysis, do it as soon as possible. Extremely, extremely important. And now think of the time it actually took for someone to get first medical contact. That was like 6 hours median time, right? So by 6 hours, most of the heart is irreversibly damaged, okay, because of the steep thing. And now if you look at the top figure, the same thing, myocardial salvage, amount of myocardial tissue one can revive back, okay, while performing PCA. Of course, if you do PCA, you could get more, get back more of the heart muscle. And of course, if you do it by 2 hours or something like that, you are likely to get about 70 to 80%. If you do it by 4 hours, you are at least getting 50% or something like that. So this time is extremely, extremely significant. There is a golden hour. You are supposed to do this in less than 90 minutes. The entire time, this is not door to balloon time. This is a time from symptom onset to actual reperfusion, getting back oxygen supply, getting back blood flow. Okay, that time, if it is like 2 hours, you can get back the heart. But on an average, it is taking about 6 hours for someone to get first medical contact. Forget PCA, just first medical contact. That's how bad situation is, and that's how important time is. Okay, And the bottom line is time is everything in STEMI care. Okay, the faster you act, the better it is. The better the prognosis is, the better you can get back heart's functionality. You know, all those factors. Extremely important. Now, ECG actually plays a very vital role in actually improving this treatment time, okay, or known as total ischemic time. This figure shows a rough, timeline of what happens, at the center. There is symptom onset, then there is transit, okay, transit through various modes, and the treatment can actually happen only if that, they get to the right center. There might be transit to a general physician, and then from general physician to a slightly bigger hospital. Then from a bigger hospital may not have some capabilities. Which capabilities will come to that in a moment. All of that are transit, and then finally they get to the place where there is a cath lab. They can do this treatment. Okay, and then after treatment, of course, there is post-treatment monitoring and rehabilitation. And we looked at door to balloon time, right? So there is also something called door to needle time. Instead of doing PCA, what is more reasonable is thrombolysis. Okay, the time it takes to someone to enter a hospital to the time you put the needle to give that anticoagulant, that is known as door to needle time. And before doing this, you want to confirm it's a STEMI. So you need to take the ECG in order to confirm it's a STEMI. If you give the treatment for the wrong person, things can be fatal again. Okay, giving thrombolysis to inappropriate patients, okay, it's contraindicated in many patients, will lead to fatal consequences like bleeding, stroke, and all that. You want to make sure you are giving it to the right person. So there is also a door to ECG time, okay, and the real time that matters is, how much of the heart can you get back. That depends on what is known as total ischemic time. The time from the symptom starts, that is there is a rupture of the blood vessel, there is clotting, from the time to actual treatment, whatever treatment you're doing, okay, that time is known as total ischemic time. If you look at this in slightly more detail, the same figure, this is things are shown here. Let's look at the right. Someone arrives, arrival of the patient to the emergency department. Then they take ECG to confirm whether it's ACS. If it's ACS, whether it's STEMI. Then once they do the ECA, they have to choose between PCA or thrombolysis. The doctors discuss it, what is appropriate based on patients, history, age, various other comorbidities, various other characteristics. And once the doctors come up with a preferred mode, they tell it to the patient. Many times patients say, I cannot pay for PCA, or what is written as PPCA, that is a primary PCA. Okay, you do PCA as a first treatment, so they go for thrombolysis. And other class of patients who could afford PCA, okay, you have to alert the STEMI team, you have to prepare the cath lab. There are of course financial processes involved. You have to shift the patient to the cath lab, and then you have to insert the sheet. You have to place the lines, you have to put the guide wire, you have to put the balloon, inflate, and then you have to put the stent. Okay, so this insertion of sheath and establishment of reperfusion finally happens there. Not finally, at least in this figure, it finally happens. Correspondingly, notice in the left we have door to ECG time, decision for PCA, consent time, STEMI team activation, financial process, so on, so forth. And all this are happening once a patient gets into the treatment room. The symptom transit is not really shown in this figure. And again, we have lots of data and what consumes, how much time. And so time is everything, and but it's taking 6 hours and all that, even for first medical contact. What is taking so much time? A lot of studies have been done on this, and this pie chart kind of shows where is time lost. About 150 minutes is lost in recognizing symptoms. Someone has symptoms of heart attack, they take 150 minutes to possibly realize, okay, they might have heart attack, and decide to get medical help. Okay, that is how bad awareness is there in a country like LMIC. Okay, this is population data, and 150 minutes is a lot. You already know by 1-2 hours you almost lost most of the viable myocardium. Myocardial salvage is not there. 150 minutes, right? You lost most of the heart, the damaged heart. But it takes so much time for someone to recognize symptoms. And then someone recognize symptoms for them to get first medical contact. Okay, it takes about 1 hour. And hopefully that first medical contact is contact with the appropriate, it's not a general physician. Often if you go to a general physician for symptoms with heart attack, again, studies shows that it takes longer. Total ischemic time is longer. One should skip the general physician, directly call an ambulance and go to the appropriate PCA center. Okay, and then of course we have pre-hospital management. Now all these times, go to ECG, decision for PCG, consent times are all very, very small chunks of the time. So this most of the time, 3.5 hours is lost in recognizing symptoms and getting appropriate medical contact. Okay, and this is where this pre-hospital ECG really plays a role. And again, studies on population data show that pre-hospital delay time among South Indian population is unacceptably high. It's high, okay, but it's unacceptably high. That's how bad pre-hospital delay time is, or this total ischemic time is. We need public education, improving systems of pre-hospital care, measure to improve this patient flow and management, emergency department, and all of that. Time taken to take ECG and to initiate reperfusion therapy, okay, in the study points a scope for improvement. If we can reduce that initial symptom onset to, getting to the appropriate PCA center, you could actually save a lot of time. A key to that is ECG. Okay, and part of having this webinar series is to actually create this awareness. Things are so bad. At least you BM engineers should be aware of it, and then of course, hopefully that knowledge spreads with your friends, family, and all that. Okay, things are unacceptably high. A key to improve this is, of course, pre-hospital ECG. Here are a list of things, list of reasons for delay in STEMI care, starting with lack of awareness of symptoms, attribution. Someone thinks, okay, they ate something, they have gas stomach disorder. Then people try to do self-medication, or family members don't actually appreciate the gravity of the situation. There is sometimes the MI is also not, painless or silent. Then there is a delay in calling medical attention. Transportation, we know how bad the roads are connected. The inaccessibility of proper medical care in remote areas. The cath lab density is very, very low. Transportation is, roads are very bad. Ambulances are very, very less. Ambulances with proper devices, they are very, very less. Okay, and of course, yeah, there we have things that biomedical engineers could really, have a high scope of improving. Poor telemedicine technology. Someone has symptoms of heart attack. Can we confirm it's a heart attack? There is a delay in hospital ambulance response times. Can we connect ambulance networks to hospitals properly? Can we have a nice catalog of STEMI care centers, cath labs, and can we connect the patient to the nearest PCA center? Poorly equipped ambulances. There is ambulance, but there is no, ambulance doesn't have a ECG facility, so that we can diagnose or confirm STEMI. Okay, the three highlighted things, biomedical engineers have a lot of scope, and the key there is doing ECG to diagnose or confirm it's a STEMI. Okay, then of course we have poorly trained paramedics. Transportation problems are there. There is high traffic, lack of primary PCA facilities. The cath lab density is very, very low, and then staff are not working round the clock. Cath lab access, okay, economic affordability. They cannot really go for PCA, whatever it costs, and then patient is taking time thinking of the amount of money it's going to spend. But what we could focus on is the high, three things with high scope for BM engineers. Other things, of course, there are scope if you want to get to, but these three things are like low hanging fruits with, highest scope. And to make it very, very short, we want to reduce delays in diagnosis and in access to appropriate STEMI care center. And we want to make the treatment more affordable. Okay. Both of them, biomedical engineers can play a huge role. Specifically, okay, what do you mean reduce delays in diagnosis and in access to appropriate STEMI care center? one of the recent white papers, okay, on resource and infrastructure appropriate management of STEMI in LMICs. Okay, they kind of categorize hospitals into 5 levels. Level 1, there is a general practitioner, okay, or it's a primary healthcare center. There is no ECG. Most of the hospitals in a rural setting are like this, primary healthcare center, even in an urban setting, okay. And then there is a level 2 facility that has a ECG available, but no TTX. TTX here stands for thrombolysis. And then we'll come to thrombolysis in a moment. Why is thrombolysis showing up there? And then we have level 3 facilities. This is a hospital where ECG is capable, and of course, thrombolysis is also capable. Okay. And then we have level 4 and 5 facilities where you could do percutaneous coronary intervention. There is a cath lab. And of course, level 5 would be a center of excellence where they do all these kinds of epidemiological studies and all that. You want to do research in STEMI, you could do it in that center. So most of the centers in India are like level 1, 2, 3. Okay. And although PCA is the preferred treatment, if a PCA is within reach, okay, take them to the PCA. But for most people, PCA is not within reach. So the suggested mode of treatment in that setting is first do thrombolysis. Okay. That is, give a drug that will clear up the blockage. And then that alone doesn't suffice in most of the people. Take them to a, buy some time, take them to a center where PCA is possible, do PCA. This doing thrombolysis first and then taking them to a PCA is known as pharmaco-invasive strategy, or secondary PCA, or best word is pharmaco-invasive PCA. Okay. Notice most of the centers do not have ECG to do diagnosis of STEMI. Okay, why is ECG so important? Because with ECG only you could actually decide, okay, confirm it's a STEMI and then give thrombolysis. If you give thrombolysis to the wrong people, it will end up in other fatal complications, bleeding in inappropriate places, say a stroke and things like that. You want to confirm it's a STEMI, and then once upon confirmation, if possible, skip the general practitioner, all this level 2, level 3 facility, or in a level 2 facility, directly take them to a level 3 facility. The faster you have ECG, the faster you could make this decision. All this time lost in, going to place A, going to place B, or this place doesn't have that, this place doesn't have that. All the time can be saved by directing the patient to the appropriate center if we have an ECG and confirm STEMI. Of course, the problem is we don't have ECG to confirm STEMI. Even to send someone to a level 3 facility, we are not sure because we don't have ECG. And this aspect is known as pre-hospital ECG. Can we do ECG on the way to a hospital, in an ambulance, or at a general practitioner public healthcare center level? Can we bring down the cost of ECG devices? Okay, reliability, robustness, and all those things. Okay, so time is extremely important. Lot of time is wasted because this diagnosis needs ECG and that ECG is missing. Specifically, pre-hospital ECG is missing. If we have that setup, you could save time. In turn, you could save, you could give appropriate treatment, and in turn, you could give, appropriate treatment in a timely manner, and in turn, you could save lives. Okay. Now, yeah, this is this pre-hospital ECG in this thing. Notice not all chest pains are heart attacks. Some of them can be due to, outside of the heart, that is non-ACS. Need not be coronary syndromes. Acute coronary syndromes can be from the shoulder, can be sometimes from the heart. Someone did not sleep properly with a pillow, so there is a pain in the shoulder. Someone did not eat properly, there is a pain in the stomach. There can be all other things. Okay, you kind of make sure it's a heart attack problem, problem with the heart, acute coronary syndrome. There are multiple problems that can actually lead to chest pain. Heart can get inflamed. Like, mosquito bites, part of the skin gets inflamed, like that heart can get inflamed. Then there can be, bundle branch blocks and things like that. Electrical circuits can get disconnected. Not just the blood supply network, electrical supply network can all that get disconnected. So what you want to do is, first, is it ST segment elevated myocardial infarction, or is it non-ST elevated myocardial infarction? Within, acute coronary syndromes, heart attacks, there are three, levels of severity. Unstable angina, the blockage is not that bad. Okay. Sometimes you have myocardial infarction, but there is no ST segment elevation. There, again, this is in between unstable angina and STEMI. Finally, you have a huge block in the heart vessel. You have, drastic difference in ECG, ST elevated myocardial infarction. Okay. You want to do this first, isolate its ACS. Within ACS, it's a ischemic ACS, that's a myocardial infarction. Within infarction, you want to classify whether it's unstable angina or N-STEMI, non-STEMI or STEMI. Then only you could give appropriate treatment. And primarily, ST, non-ST, ECG is used. Of course, within unstable angina, non-unstable angina, there is something called troponin. Some biomarkers are used. That's a topic for a separate talk. Okay. So if you have an ECG, you can quickly say, confirm that it's STEMI. Because you already showed some ECGs, the ST segment will be elevated in that STEMI. So save time with ECG and intern, pre-hospital ECG and intern lives. Okay. So doing a triage in a point of care center. We have listed lots of complications that can actually lead to a chest pain and often confused with heart attack. Bundle branch block, left ventricular hypertrophy, STEMI, non-STEMI, unstable angina, old STEMI with aneurysm formation, pericarditis, that's inflammation, coronary spasm, some dynamic problem with the vessels. Okay. Conduction disorder, conduction abnormality. Again, bundle branch block is one of the conduction abnormalities. Electrical conduction can be other conduction abnormalities. Okay, there is actually STEMI, ST segment elevation, but some cases it's also benign. There is airway repolarization. Or actually, it's not at all acute coronary syndrome. This triage you want to do. Typically in, primary health care center or a general practitioner center, or, at least in an ambulance. That system is not prevalent. That is missing in most parts of LMICs, STEMI care systems. Engineers can come up with better, cheap, portable ECG devices and also good ECG classification algorithms that will automate or make this process more efficient, or faster, or aid a expert making that call faster. Okay, so be it in a device side or a machine learning, artificial intelligence side, biomedical engineers, there is a gaping hole, and BM engineers can play an important part. Okay, and of course, before we finish, with pre-hospital ECG, you could actually reduce total ischemic time, which is the most important factor, and eventually, improve treatment, give appropriate treatment, and all that. But so this happens during transit. Can a person get to the right place, as soon as possible? Make a decision with ECG, pre-hospital ECG, take them, and also, or appropriate people given thrombolysis. That also can be done with a pre-hospital ECG. Then after treatment, there are also complications. ECG, significance of ECG doesn't stop here. In the acute scenario, this is the most, the significance is this, but ECG, of course, also has significance beyond this acute setting. So there are some complications during and after PCI. Okay, we give thrombolysis, we give anticoagulants. Did the blockage actually resolve, or is the blockage continuing, or the blockage occurring again after some 30 minutes, after an hour, after 6 hours? Okay, there are a lot of complications following PCA, or specifically following thrombolysis, which is very, very common in LMICs. Okay, one of them is what is known as reocclusion. Yeah, what is very realistic in a LMIC is, at best, there is a level 3 facility where they can give thrombolysis. Once they give thrombolysis for a presumably and very likely STEMI patient, they take them to a level 4-5 facility. And I say, as I said, to do a PCA, and I said this is known as a pharmacoinvasive strategy. And when they give thrombolysis, often there is reocclusion. Okay, that is temporarily the blockage resolves, but again things get back. There is a blockage of that artery again. There is continuous ST monitoring, okay, in order to actually see if there is a reocclusion or not, whether the thrombolysis treatment worked or not. Even PCA, following PCA, there can be some complications. Again, you need continuous ST monitoring. Again, a nice ECG classification system, algorithm, artificial intelligence machine will save time for the experts. Experts can spend time on uh, emergency patients, because their time to look at the ECG, make the decision is kind of reduced or saved, because you have a nice algorithm in place, nice machine learning algorithm in place. So continuous ST monitoring is important. And again, treatment depends on how viable is a myocardium. How much of the myocardium can we get back? Again, ECG, some features of ECG is a very good measure of that. Okay, and there are problems like reocclusion and all that. So continuous ST monitoring is also important. At least you could save the experts time there, who could attend to more number of patients. Okay, and finally, of course, post-treatment, notice heart attacks recur. Okay, there is a second attack, there is a third attack, and all that. Now this comes to, there is also rehabilitation. Someone has to get back to normal life, right? So there is also post-treatment monitoring. This is where things like wearables kind of play a role. Okay, and of course, eventually there is eventually there is a symptom, and then the cycle kind of continues once or twice. Okay, 2 heart attacks, third heart attack, by that time it kind of becomes very, very severe. So starting with the most significant pre-hospital ECG, there is a gaping hole, following with continuous ST monitoring to give appropriate treatment, followed by monitoring rehabilitations, or can we predict impeding heart attack based on continuous monitoring, or using a wearable ECG device? Those are also important questions in the long run. Okay, and what we want to do was, today we spoke about the need for this. Okay, we want to keep going. Okay, this is just like setting up the stage. As I said, objective of this is to make cutting edge research accessible to a large class of biomedical engineering students. If we get to IITs, if we go abroad and all that, in a handful of labs, they do this cutting edge research. Sometimes also happens that colleges outside of IITs, but they are in a handful of labs. But if we kind of make it accessible to everyone, tell them how to get started with this ECG classification problem, how to build a simple ECG device, things like that. This research will be more democratized. Okay, there is kind of like a catalysis going on. All this rates of innovation is expected to kind of increase multifolds. Okay, which is the objective of this. So today we set a stage for this. Notice there are 3 publicly available data sets: European STT, long-term ST, and STOF3. Okay, what we eventually want to do is to take these data sets, tell them how to do some simple ECG classification using machine learning. Some of the things you learn in a handful of labs, under few profs in some IITs or even abroad. We want to make it accessible. We want to make it accessible. Whether they make use of it or that is a second question. We want to teach you, how to use this. Often even some intern programs kind of get money from you and teach this, but we want to take a more democratic approach. More advanced things are, we want to make it more accessible and more free. And so our next objective is to help whoever is interested, biomedical engineers and students get started with this problem. Okay. Um, some of you, there are some intern companies that might get, payment from you and teach you how to do some simple machine learning problems and all that. First of all, good interns not are supposed to pay you. You're not supposed to pay good interns, but by making it open, publicly available, we think we could reach more students. Okay, that's our objective. And of course, if you are an epidemiologist, if you are interested in public health and all that, there are lots of Indian registries. This is typically, doctors make use of it, epidemiologists make use of it, create Kerala ACS and all that. But publicly available, we have 3 available data sets. And again, something like an Indian data set is missing. All the 3 available data sets are from Europe or US. Once we have this critical mass of BME students and researchers working on this problem in the cutting edge, we are also expecting to have a nice ecosystem of biomedical research. Okay, that is our long-term goal, and this is our first step. We'll keep continuing with this. Okay, and yeah, today we spoke about the need. We'll keep continuing with this webinar series. Subsequently, we'll talk about how to get started with it. Again, it will be accessible to everyone. And finally, we'll also point out where is some cutting edge research going on. Even researchers in the West in a handful of labs or kind of get stuck with this problem. This is a problem. If you're interested, if you're curious, and if somewhat lucky, can you solve that? Okay, we'll take it to you. We hope to take you to that till that stage. And so hopefully, today's I'm sure you learned at least some of the jargon and came to know some data supported opinions and perspectives. Okay. I thank Prabha Lakshmi for helping me on this. So one of my past students, BM engineer right now, who kind of again has similar views on taking this research accessible to a wider class of BME students and kind of creating an ecosystem of biomedical engineering research. Okay, or democratize BME research. Thank Prabha Lakshmi. Okay. I already gave the disclaimer, all the opinions, all the views expressed are personal opinions. Okay. But all of them are supported by documented evidence. Okay. We had references whenever required. Okay. And one of the things is, yeah, I already said subsequent steps. We want to get started. Also want to show you where cutting edge research problems are. If you are interested in this, sign up for subsequent webinars. Okay, by filling the form where the QR code will take you to a form, very short form. Sign up for it. We'll let you know of subsequent webinars. Right now, we are addressing students, and we are hoping that the team gets larger and we get to address a larger class of larger class of concerned stakeholders, and eventually actual real world changes in healthcare. Okay, so let's kind of warm down and finish the session, and then I'll open this up for discussion. But let's do a quick review or recap of where we are. So is STEMI diagnosis with pre-hospital ECG possible? Okay, so first 4 questions are in most rephrased questions that are I initially posed. So how many of you think we could do a pre-hospital ECG and do a STEMI confirmation? How many of you know? No, none of you think it's possible? Great. At least I see a couple of hands. But I'm sure all of you understand the question, right? Yeah, that's the significance on the problem and that awareness. Of course, one of the takeaways. Great. Actually, I'm having lots and lots of hands rising up. So how does someone with MI get to the nearest PCE capable center? There are lots of modes, and the best is ambulance. And they also, the right person needs to get to the PCA as soon as possible. Can we streamline this process? Can biomedical engineers play a role in streamlining this? Right now, they take all kinds of detours. Take diversion, and by the time they get to a hospital, all the heart, most of the heart is dead, right? Can this be streamlined? Or in other words, how do we improve total ischemic time? I spoke about pre-hospital ECG. Is there any other ways this time could be saved? One of this is streamlining this STEMI care system, ambulance networks and all that. Can you play a role in it as a biomedical engineer? Can you equip ambulances with better technologies? Right? Yeah, again, there are a couple of hands going on. Which I'm as far as you actually follow the questions, I'm very happy about this talk. Okay, and also, what is a pharmacoinvasive strategy? That's also here. We'll hear about it either in the chat or some of you could use the mic. Yeah, telemedicine services can play a good part. In fact, one of the things is, can you take a ECG? That device can send it to a phone, smartphone, nearest available smartphone. One of the friends, relatives, someone has a smartphone. Can it be sent to a smartphone, and then that ECG be either through WhatsApp or something like that, sent to a expert cardiologist for STEMI diagnosis? Can that system be done? Because WhatsApp is very prevalent, right? Telemedicine services. Can these things be done? Yeah, very important thing. In fact, if you look at the white paper on that LMIC resource and infrastructure constrained STEMI care, they mentioned this telemedicine services using WhatsApp to transfer ECG and getting an expert opinion as one of the things. No. Can use public transport? No, public transport is taking a lot of time. Even meeting a general practitioner on the way is taking a lot of time. It's not recommended. One of the reasons is, you go to a public transport, you go to the hospital, how much time will it take for you to locate the emergency department? You will run someone with someone in your hands or something like that. You will run, people will, of course, people are kind of empathetic. They want to take action, but you might be at the wrong end of the hospital. It might take time to get to the emergency department. If you take the hospital, you will get to the emergency department on time. And also the ambulance, if properly equipped, will alert the STEMI care team. Okay, this is STEMI, very, very likely. Will alert the PCA team, will get the cath lab ready. All those are not possible in a public transport. Okay, making nice ambulance services, well connected. Something like teleradiology. This is an interesting idea. There is something like sonothromboembolism. You can use ultrasound to lyse clots. Technology is not prevalent. It's also still in the research side. Okay. Yeah. Can you do PCA or something like PCA or thrombolysis earlier than a PCA center? That's a harder question, but yeah, nice question. Okay. Teleradiology, but still you need that angiogram machine. Yeah, and interventional cardiologist needs to be there, unless there is a very expensive robot or something like that to do that thing. Interventional cardiologist, notice they are looking at a 2D projection of a of this blood vessel network and entering it and putting the stent in the right place. It's not a very easy thing to do. Angiogram is a 2D projection. Through that, they have to enter the right vessel. Using some guide wires, they control it outside of the body. Right? Teleradiology, yeah, okay, nice idea, but there are much more pressing, significant things, nearby things. Okay, fine. Okay, what is pharmacoinvasive strategy? AA-aided ECG acquisition, yeah, that is one of the things we could do, and that's one of the things we want to get started with. Okay, fine. So what is pharmacoinvasive strategy? Any one of you answer that, we'll just move on. And while I think about it, ECG alone usually, is not very specific. STEMI can, ST segment elevation can occur due to many other things. Often they use something called a troponin or CKMB to say there is myocardial injury. Okay, so we also need point of care cardiac biomarker testing. Okay, but this talk is for for another day. Again, an important need. Pharmacoinvasive strategy. So doing primary PCA first is not feasible not realistic in an Indian setting, LMIC setting. Although that is the preferred treatment. So they give drugs first, thrombolysis. Then they do PCI. That is known as a pharmacoinvasive strategy. Okay, so there is PCI, primary PCI, pharmacoinvasive strategy. Then the drug you gave did not work. That is known as a rescue PCI. Things like that. Okay, there are differences. Okay, so and this is specifically for YouTube because it's going to go public. Okay, this is for educational research purposes and all that. And we are, this is for fair use. And here are some of the references if you want. References for all the figures that we have used other than Wikipedia Commons are given here. Okay. And because, okay, the stock is available, you could always get back to the stock and look at the references. Now let's open the table for discussion. What are your questions and thoughts on this? On either pre-hospital ECG or streamlining STEMI care or democratizing biomedical research like we are trying to do now? Talking about the need, getting started, talking about open problems, eventually, of course, solving open problems and all that. Let's have an open discussion and then, 5-10 minutes, we'll wind up. So, first question, let me actually streamline this discussion. Is such a thing needed in India? That is, STEMI care, ECG, and all that is needed. Is biomedical research, democratizing biomedical research, is that needed in India? How many of you think that is important? Do we need webinars like this? Do we need instructional videos on how to do ECG classification? Okay, couple of you think. So interestingly, I'll try to be semi-private. Many hands rose up. Most of those hands are from NIT. I won't mention which NIT, but it's from a NIT. So even students at MIT seem to think, okay, we need this kind of a platform. We need this kind of discussions. Okay, that's good to know, and I am surprised by students. NIT reasonably you get better education, but I'm sure the detail, the amount of work that go behind this. This is not reading one Wikipedia article or one research paper. You cannot get this. Okay, a lot of work go behind this. I already mentioned, we have been working with Prabha for a reasonable amount of time, and I have been working on acute coronary syndromes since my PhD, more than 10 years. I have worked with blood, I have worked with heart, I have done, I have placed lines, I have worked in ICUs, cath labs, spent time there. Okay, I have done postmortem on pigs and all that. So a lot of work has gone behind this, not information that you would easily get outside. Okay. Okay, so others think about it. Okay, are there any other questions, comments? Of course, that I hate this to be a monologue, right? What do you want next? Can we have like, okay, these data set are there. This is the program you have to install. This is the script you run it. This is the classification you do. Some basic primer on machine learning, and then specifics on ECG classification. Even starting with what kind of a platform should you install? Say you are using a Mac or a Linux. Instructional videos on that, would that help? There are lots of instructional videos on machine learning, but specific to STEMI care, ECG, biomedical engineering, not. And more specific to LMICs, certainly not. Okay, and some of the things we are talking about, even if you go to IITs, you may not get it. Okay, so should we continue with this? Yeah, I already got a hands for this. Any preferred directions for continuation? What are the things you would like to have next, or you would like to have BME students to have next? There's this big silence. Okay, fine. See, honestly, I thought about 10 of you, handful of you would show up. 20 of you showed, 21 of you showed up and kind of stayed till end of the talk and the meeting. Okay. So this is very good. Irrespective of numbers, despite numbers, we think this is right thing to do. Epidemiologists, doctors are doing amazing work. Okay. It's time for biomedical engineers to catch up. Instead of complaining about lack of jobs, start solving real world problems. In the process, you will have to learn a lot of skills, catch up a lot of jargon. Yeah. And learn them. And we certainly think this is the right thing to do. Okay. And we'll continue on with this. So let's hear from Prabha, word or two, and then we'll finish. Prabha, your thoughts? Okay, so we have some things. 1 second, Prabha. What was most needed during COVID from our side, pandemics? Yeah, I can actually tell you right now, one of the greatest engineering challenges, one of the greatest medical challenges of our time is this problem called sepsis. Okay, septic shock, which is where things get very severe. Most of the ICU deaths, intensive care unit deaths, happens due to septic shock. Very prevalent. Also, the moment there is septic shock, that's where doctors say it's not in our hands anymore. You can at best give supportive treatment, try to keep the patient stable, vital stable, but it's not in our hands. There is an open problem. Okay, and many people in COVID, people who die get very severe blood coagulation problems, get very severe infection problems, sepsis, and all that. So many deaths could have been avoided if we had better knowledge about how to revive a patient back from septic shock. No one knows that. Doctors don't know that. Biomedical engineers, scientists, physicists, no one knows that. And that's a very open-ended problem. Any advancements in knowledge could have had a major impact on COVID from the treatment side. We had major impact from the prevention vaccination side. From the treatment side, we could have had a major impact. Okay. Yeah, sepsis, it's an open challenge. Okay. We'll talk about it. Okay. We'll finish ECG. We'll get back to that now that sepsis is there. Whether COVID is there or not, sepsis is there, occurs in many other things. Thanks for reminding that. That was there in my agenda. And it's also somewhat related to my PhD thesis, coagulation, and all that. We'll try to make a very objective, scientific awareness video on sepsis. Okay, what are the new technologies worth learning for biomedical software tech domain? Yeah, part of getting started actually will automatically put you there in that. People talk about blockchain. Is blockchain really changing things, or even a centralized things will change? Machine learning. Okay. Getting started in artificial intelligence is a technology of our data is the oil of our times. Artificial intelligence is a technology of our time. That you'll also touch upon software and tech as much as possible. Okay. We'll also try to collaborate with engineers outside. Okay, so that to make it we want to at least we want to set up a stage for open conversation, invite experts, give them talks and all that. Yeah, that is there in the agenda. We'll certainly do that. We want to talk about technologies and innovations. The problem is need is the most important thing. Always start with the real world problem. Many technologies, many innovations are like namesake and doesn't end up anywhere. Okay, we want to avoid that. At least prune things at the weed out things at the beginning itself. That's why we spend so much time on need for pre-hospital ECG. Okay. And whenever we talk about technologies worth learning, we'll always start with the right need. Today, pre-hospital ECG, sepsis, again, there is a right need. One by one problems will certainly address that. Okay, thanks for nice suggestions. All of them coming from one student. Others? Okay, so nice. Yeah, Prabha wanted to say a few words.
Hi, sir. Thank the session was really useful for all of us. And also thanks for guiding us to find the real world solution as a biomedical engineer. Thank you so much for your guidance on this.
Sure, Prabha.
Thank
So yeah, yeah, I certainly know I cannot do it alone. Certainly, this talk, your work, all the references you fetched, the details you fetched, corrections, editings that you made, cannot go unacknowledged. Okay, thanks for doing that. And I'm also hoping to get more support. One person cannot change things, change reality. We need a critical mass of awareness, knowledge, and actions. Okay, focused actions. We need a critical mass of that. That's when real world change will happen. I'm hoping that you know we organize this, we do this in a more systematic way. Thanks a lot, Prabha. And yeah, I'm glad this session was useful, and we hope to continue this. At least Prabha has afforded her time on weekends. She's a working professional, but she has afforded her time on weekends at least till September. And you already know that because I only teach, or I kind of has this blended learning, use technologies in teaching, so that I only teach on weekends. I have weekdays to work on this. This was not feasible last year, during the pandemic and all that. Now things have become feasible. Again, I'm fortunate and blessed, okay, to have the time, to have students, to have a team team like this. I'm also glad we kind of start getting actionable. Prabha, me or myself, someone correct me from our English class. We have been having this iterations, a lot of iterations. We wanted to get actionable, some awareness material out there. It's an ocean of things. Where is all this knowledge lost in the ocean of information? Where is all this wisdom lost in the ocean of knowledge? That's a problem of today. We have too much data. We have too much research papers. We have too ocean of things. Okay, we wanted to isolate really important things, pinpoint at it, so that we can improve our focus. So a lot of work went behind this, and this video is our first outcome. This will go public, and we hope to continue on this. Okay, so I think we had a useful Saturday evening, I suppose. At least monthly once we are planning to have something like this. Okay, so yeah, had a nice session. I'm really fortunate and blessed. Okay, so I'll see you again with subsequent webinar series. Okay, some of this we will also learn in the class, but we cannot go deep in the class because we are kind of focused on the gate. It's a good place to stop, and we'll notify you of if you sign up for this webinar series. Okay, so have a good one. If there are no other questions, we'll stop here. Okay, nice place to stop. Have a good one. So I think I'll see most of you in class tomorrow. So yeah, see you in class tomorrow. Bye everyone.